Now moving on to our second section, that is the scapula fractures. As we know, we are discussing the shoulder injuries or injuries around the shoulder girdle, and there are multiple bones around it. The one is the clavicle, the other is the scapula. Scapula is actually attached to the proximal humerus and forming a glenohumeral joint. In this section, we'll briefly discussing the mechanism and its clinical features of scapular injuries, how to use image to actually classify these injuries, and what its management along with its complications. Fractures of the scapula. Now, as you know, it's a mechanism of injury is usually most of the time is very high energy trauma. And usually the scapula does not get broken, but once it gets broken, this means there is definitely a very high energy trauma which has been a lot of energy was imparted through the upper limb, and there may be associated neurovascular injuries as well. So if you see a scapular fracture, you need to look at multiple things at times. What you need to look at is, because this is the scapula, it is joined to the proximal humerus and form a glenohumeral joint. It forms a joint over here. This is the acromion, which is actually forming a acromioclavicular joint with the clavicle, and this is a coroid. This is coracoid. Now this coracoid is actually attached. There is a short head of bicep is actually getting off from it. Now the important point is if you need to view it as three different structures. This is the scapular blade, then there's acromion, and then there's a glenoid cavity, and you need to look at the scapula as from these three angles, and they classify the injury. There are different classifications as well. It's, as I told you, it's due to high energy trauma, and usually considerable force has been applied, and you need to look at the associated injuries. Could be multiple. There could be pneumothorax, hemothorax, rib fractures, intrathoracic injuries, neurovascular injuries with the upper limb as well. There could be torn ligaments or muscles at times as well. Coming to the mechanism of injury, as I told you, the coracoid, as there's a high energy trauma, this could be damaging the coracoid as well. This could may be associated with fracture of the acromion and disruption of the acromioclavicular joint as well. This could be the fracture of the glenoid fossa as well. Now, one thing, that is why when scapular fractures are present, we need to look at the scapula from three angles. Why? Because it's making one joint with the clavicle, that is acromioclavicular joint. The second joint is with the basically the glenoid fossa in form of a shoulder joint or a glenohumeral joint, and the third is the coracoid itself. So that is how the fractures has to be looked upon. That is why we'll discuss that in the classification as well. Now, clinical features, usually the first and foremost is the patient will tell you that he or she has an RT. The patient will not be able to mobilize the arm very freely. There will be definitely tenderness and pain, especially over the scapular blade. There may be severe bruising over the scapula or the chest wall, and if it's associated with other injuries, there may be other problems as well. There could be damage of the scapula, especially when you press the scapular blade due to fracture. There may be severe tenderness. There could be associated injuries as well. There may be rib fractures. There could be pneumothorax or hemothorax as well, and there may be other signs which may present as well. Now, it is a high energy trauma, this may be associated with the polytrauma. There may be spinal cord injuries, there may be abdominal injuries, there may be thoracic injuries along with this problem. So you have to take it up. This is usually a very high energy trauma, and we have to look at the patient as per ATLS guidelines. That is the airway, the cervical spine, then breathing, and then circulation. We cannot, if it comes out to be luckily an isolated scapular injury, then what happens? Then we need to go for imaging. Then the first is to go for an X-rays. That's usually, it's difficult to describe at times, but X-rays is going to tell us, at least going to tell us what is the wrong with the glenohumeral cavity, what is wrong with the coracoid and acromion. At least on AP view we're going to go through, we would come to know as well. But scapular blade fractures sometimes are not very easily visible, because usually then we have to go for AP of the scapula, which is axillary view, in which a patient is lying supine. Usually the arm is slightly abducted and externally rotated. It's very simple. You hang a post near to the patient. You ask the patient to hold that post. When that patient is holding that post, his arm is actually abducted as well as externally rotated, and in such a way that beam is directed into the axilla, with the plate for the radiation plate is actually placed behind the scapular blade. And then this view is taken as, this is called an axillary view. That will actually tell us exactly the fracture configuration regarding for the scapula. Other options could be scapular Y view as well. Now this can also be done because we need sometimes this may be associated with anterior posterior shoulder dislocation as well. So glenoid cavity would be more clearly visible, and whether there are fractures as well or not, the displacement of fractures fragments or not, usually would be very easily visible in scapular Y view. But the best option is to go for 3D reconstruction with the CT. That will actually tell you everything regarding what's the situation in glenohumeral joint, acromioclavicular joint, what's the situation coracoid, what's the situation scapular blade. Now coming to the classification, it was given by Heidelberg, which was basically divided into the fractures of glenoid neck and scapular body. They have divided into two. Later on, it was actually modified by Gauss that they included acromion as well as coracoid process fractures as well. So actually, the scapular fractures have four parts. One is the scapular blade, the other is glenohumeral joint, then acromioclavicular joint and coracoid, and they are described in a different classification. Intra-articular glenoid fossa fractures are actually, these include 6 types. Type 1 is a fracture of the glenoid rim, fractures through the glenoid fossa, inferior fragment is actually with subluxed humeral head. Type 3 is an oblique fracture through the glenoid exiting superiorly. Type 4 is an horizontal fracture which exits medially. Type 5 is a combination of 4 which with another line exiting inferiorly as well. Type 6 is a severely comminuted fracture. So intra-articular glenoid fracture fossa may be seen as well. Then there could be fractures of the acromion as well, which could be minimally displaced but not reducing the subacromial space, or it could be so inferiorly displaced that it is actually impinging on the subacromial space. Then it could be in form of coracoid process as well. Then the proximal attachment of the coracoid-clavicular ligaments may be disrupted, or it may be due to distal to the coracoid-clavicular ligaments. So that is how it's taken. And the fourth type is when only the scapular blade is actually fractured. That these are all include the extra-articular fractures of the scapula. Now coming to the treatment. Treatment is actually, if there are body fractures and all those extra-articular fractures, usually surgery is not necessary. The management is wearing a sling for comfort till the fractures heal and the pain eventually settles down, and then we can start the range of the motion in form of act exercises to the shoulder, elbow, etc. If it is an isolated glenoid neck fractures, now that is important. And usually there are polytrauma patients associated, but if the patient's airway is secure, there is no associated cervical spine injury, the breathing is breathing normally, there is no hemothorax, tension pneumothorax, or other associated thoracic injuries, circulation is not hypertensive, he is vitally stable, and it comes out to be isolated glenoid neck fractures only, then what we know, it can be frequently impacted. Usually the sling is worn for some times and eventually early range of motion is started. Then comes to intra-articular fractures. Now intra-articular fractures means which are actually involving the glenohumeral joint. Intra-articular fractures means type 1 glenoid fractures, which is actually the minimally displaced one. Sometimes, although the surgical fixation is required because they're intra-articular, in which there may be associated anterior rim fractures, and approach is through the deltopectoral approach. If it's posterior rim fractures, then we can go through the posterior approach depending on which part of the rim is injured. Now coming to the type 2 fractures. Type 2 is fractures in which there is not only displacement but subluxation of the head as well. It usually requires an open reduction and internal fixation. Open reduction and internal fixation could be in form of plates or screws, or it could be in form of other procedures as well. Approach is almost similar to the type 1 as well, usually either the deltopectoral or the posterior approach. Now other options, which is the type 4, in which there was an oblique fracture and transverse fracture which was exiting through the medial wall, in which if this is the situation, or type 5, in which this not only is going through the medial wall but also going down as well, and usually type 6, in which multifragmentary or comminuted fractures, then the treatment is open reduction, internal fixation. Usually, although they have a poorly defined indication for surgery, but most of the time as they're high energy trauma, we have to go for surgery, and excessive medialization of the glenoid is done. And cutoff limit for intra-articular step is 5 mm. If it is more than displacement, there is more than 5 mm of intra-articular step, you have to go for open reduction and internal fixation of these fragments. Only if it's less than 5 mm, then you can take a non-operative approach. But usually with these fractures, we have to go for surgery for most of the time. Now, as I told you, the one was scapular blade and extra-articular fracture. The other was the fracture, intra-articular fractures involving the glenoid fossa or the glenohumeral joint. The other two were the acromion and the coracoid process. The fractures of the acromion include undisplaced fractures are non-operative. Subacromial space reduction are the operative. That is, if they're impinging on the subacromial space, then they need decompression plus fixation. Now coming to the coracoid process, if you see this coracoid process over here, this is the long head of the bicep which is coming through the rotator interval. The short is really originating from the coracoid. So associated with acromioclavicular separation at times as well, and it usually needs operative treatment, because there are other, not only the short head of bicep is attached to it, there are the two ligaments, coracoclavicular ligament, the trapezoid equinoid are also attached to it here. Now coming to the combined fractures, there could be associated, if you see this x-ray, this is how the posterior rim is also injured as well, along with seems to be subluxation as well of the humeral head. And if you see this is probably scapular Y view, showing that there is a posterior dislocation of the humeral head along with the glenohumeral fractures. If there's mass displacement or a floating shoulder is a term which is used when there is actually scapular injuries, there's a clavicle injuries, and there's a proximal humerus injuries as well. In this, the shoulder becomes a floating shoulder. Usually that means there's absolute indication for surgery. But you need advanced reconstruction imaging. Why? Because we need to orient ourselves and properly plan the surgery, and what are the different types of fracture which are present and how we can deal about it. The option is always, in case of a floating shoulder, is an operative fixation, that is open reduction internal fixation with either it could be plate or screws, or it could be even nail as well. Now coming to a very rare disease term, but that is called a scapulothoracic dissociation. Although it happens rarely, but it can happen with shoulder injuries. And as I told you, shoulder injuries is usually massively high energy trauma, and sometimes with high energy trauma, this could result in a scapulothoracic dissociation as well. It's a high energy injury. The scapula and arm are wrenched away from the chest, rupturing the subclavian vessels and brachial injury. Clinical features include flail or ischemic limb, swelling above the clavicle from expanding hematoma, and lateral displacement of the scapula. Treatment, as I told you, it's associated with neurovascular injury, usually high energy trauma. There may be associated with intrathoracic injuries as well. So the first and the foremost is the patient is resuscitated as per ATLS guidelines. We have to make sure the patient's airway is intact, patient's cervical spine injury is ruled out, and it's associated with breathing problems such as pneumothorax, hemothorax, tension pneumothorax, flail chest. All these have to be dealt first. Along with them comes the circulation. Patient should not be in the shock as they associated subclavian injuries. And then from after resuscitation, as per doing the primary survey per ATLS guidelines, you move on to secondary survey. Outcome usually surgery is very poor. Functional outcome depends upon the neurological injuries, whether there has been disruption from the roots, avulsion is there or not, or there is associated how much degree of brachial plexus injury is present or not. At times you have to treat the surgery. The options are surgical, but may be associated with a very long-term morbidity and mortality. In this section, we have briefly gone through the injuries of the scapula. There are different classifications for us, but we must know that the scapula forms a joint with the humerus and form a glenohumeral joint. And intra-articular glenoid cavity fractures have to be dealt properly, usually require operative fixation if they are displaced more than 5 mm. The next joint is between the scapula and the clavicle and form a acromioclavicular joint. If they're associated with coracoclavicular ligaments, then we may be requiring a surgery for the reduction of the acromioclavicular joint. Coracoid usually requires surgery. Why? Because there's not only the coracoclavicular ligaments are attached to it, plus the short head of the bicep is attached to it as well. So only the surgery which are managed conservatively in case of scapula are the extra-articular scapular blade fractures, which can be easily managed with conservatively. Thank you very much. Keep watching sqadia.com.